My name is Laurent Proulx. I'm the Executive Director of Procure. Mesdames et messieurs, ladies and gentlemen, welcome to Procure's conference series evening, our biannual event to educate and inform men and their families about prostate cancer. Tonight's conference is entitled Prostate Cancer, External Radiation or Brachytherapy. We wish to thank all participants following us via web, since the conference is broadcast live in both French and English on our website procure.ca. Nous tenons à remercier tous les participants dans cette salle et ceux qui nous suivent par le biais de l'Internet, car la conférence est diffusée en français et en anglais sur notre site web procure.ca. A special salute to our support awareness group from the Brome-Missisquoi region, who did a great job in promoting the event and organizing a group webcast. Special thanks to Dr. Taussky, who has gratefully accepted to share his time and knowledge with this audience, and Mr. Victor Glazer, a prostate cancer survivor, who will share his story with us. And also a grateful thanks to our sponsor, Janssen, who made this evening possible. A few reminders before we start. Si vous n'entendez pas la voix de notre traducteur depuis le début de ma présentation, assurez-vous que vous êtes sur le bon écran en français. Si ce n'est pas le cas, allez au bas de l'écran et cliquez sur le bouton version française dans le coin inférieur droit. There will be questions and answers session after all the presentation, so hold on to your questions. Those online, you can submit your question in French or English by using the Ask a Question button. They will be read during the Q&A session. Alors, pour les questions, vous pouvez les poser en français ici dans la salle et en anglais. Who are we? Procure was founded in 2003 and is the only charitable organization in Quebec to be devoted entirely to the fight against prostate cancer. Procure's mission is to provide science and humanity with the means to help prevent and cure prostate cancer. We work on three fronts: research, awareness, education, and support. On the research side, we have a biobank. What is a biobank? Well, in 2007, Procure decided to launch this biobank where 2,000 Quebecers gave their prostate, their blood and urine, and also filled out a questionnaire about the way they were living and everything. So we are able to have this material to be given to researchers. The four centers, the medical faculty from the CHUM, le CUSUM, le CHU à Québec et le CHU à Sherbrooke, and the Fonds de Recherche Santé du Québec all participated in this biobank. So the content of all those prostates is contained in freezer in all the university center, and we have all the information about those patients and all the data pertaining to those patients. We have started 2 years ago a process of distributing the specimen. We have a project with the United States, the National Institute of Health, where they are categorizing and full genome analysis of the prostate cancer. We're one of the biobanks selected in the world for prostate cancer. We have also a project in Quebec on new cancer recurrence markers. Our events. In the awareness area, we have major events. One of the events is the Walk of Courage that will happen during the weekend of Father's Day. So on June 21st, you're all invited to the walk. It's a 5K walk on Parc Jean-Drapeau, Île Sainte-Hélène. It's a nice venue. So the cost of registration is $50. You got an income tax receipt, so you can join us and participate with the major teams, the Impact, the Alouettes, and the Montreal Canadiens. We also have during that weekend a cycling tour where 200 cyclists will up north and also on the Parc Jean-Drapeau, Circuit Gilles Villeneuve, raise money for prostate cancer. Last November, we've launched the Bovember event. And also that Dr. Taussky has the bow tie. I didn't wear it tonight, but he has a bow tie. And that's a product that we've launched on November, and we called it Bovember. The idea is that we sell bow ties, and with that we raise money and we raise awareness for prostate cancer. So Jean Paget was the designer of the bow tie, and we're going to announce over the next few weeks who's the designer of the 2015 bow tie. November 19 was designated as the Prostate Cancer Quebec Awareness Day. It was voted at National Assembly. So it's now part of the International Men's Day, where November 19, we're all inviting our Quebecers, men and women, to wear a bow tie during that day. The last pillar is the education and support. We have 7 good reasons to use Procure support services. The first one is our toll-free number 24/7. You can call, and a healthcare professional will be there to help you and answer your question. We have a turnaround of about 24 hours. You can call, email, and they will answer your questions. Just remember the number, it's 1-855-899-2873. We also have a website where you can find questions to ask your doctor when you've just been diagnosed. So you want to find out more about prostate cancer, you can log on to our website. It's a bilingual website, and you can have all the information about the different treatments or the different questions you should ask your doctor. Our conference series. We have one conference in April in English that is always translated in French, and we have a conference hosted in Quebec City where it's translated in English. So you can, as people are sitting in their living room, you can assist at the conference on the web, and if you missed the date, we will provide the whole content, French and English, on our YouTube channel. We have also a blog where on a monthly basis we'll have 3 news articles that are pertaining to treatment, different types of new products out there, new drugs. So you just consult our blog section and you have all the questions pertaining to that. We also have a newsletter that is published twice a year, once in June and once in December, where we make a review of all the events that have happened for the last 6 months, also the news about the different treatment or the news about what's upcoming in the next 6 months. If you want, you can also call or email us, and we'll provide you with a free book that was written by Dr. Sad and Dr. Michael McCormack. So it's available in French and English, and we'll ship that book freely, free of charge. It's Understanding the Disease and Its Treatment. We also provide some new publication. We've got 3 publications. One is about, are you at risk? Think about it. The other one is your diagnosis knocks you out. This guide is for you. And the last one is the 7 ways to help you. This is all available for free. You can reach us by sending an email or even calling us on our 1-800 number. Since 2003, Procure has been investing $4 million from donation in research on prostate cancer. We've responded to more than 5,000 calls and emails from men with prostate cancer and their relatives. We have organized more than 300 general public conferences throughout Quebec on the disease, the importance of screening, and new treatment options. This is what Procure does. So if you have any question about the disease, you can call us or ask a question at the end of the presentation. Our next speaker was born in Switzerland in 1968. He studied radiation oncology in Zurich and Geneva. He then pursued his education with a subspecialty in prostate cancer, brachytherapy, and external beam radiotherapy at Princess Margaret Hospital in Toronto. Since 2004, Dr. Taussky is managing an uro-oncology team at the Department of Radiation Oncology of the Notre Dame Hospital in Montreal. He's also an associate professor at the University of Montreal. Dr. Taussky has treated more than 750 prostate cancer patients with brachytherapy and several hundred with external beam radiotherapy. Please welcome Dr. Taussky, radio-oncologist from the Notre Dame Hospital at the CHUM in Montreal.
I have to congratulate you that you came tonight. It's not easy for a man to come, and to listen about a disease that maybe he has this disease, or maybe there's some risk that he will have this disease later. We men, we are not very good. Women are much better. They're better organized. Everybody talks about what's her name? Angelina Jolie, and how she got her breasts taken off, her ovaries taken off, and that's all in the public. You couldn't imagine a man talking about that in public. So congratulations that you came today. So many who have prostate cancer, they feel a bit like this man here. It could be one of those things that crawl into your ear and lay eggs, and the eggs hatch and burrows into your... Nope, it looks fine. I know everybody who has a cancer diagnosis hopes that this will be the case, but then when you realize, no, it's really cancer, what should you do? So the outline of my talk is to talk about some numbers, prostate cancer, risk factors, early detection, screening, staging, very important subject, the different treatment options, advantages and disadvantages of the treatments. It's for sure if I talk for about an hour, I can't go really in depth. But if you have questions afterwards, if you want to know things more in depth, please ask them. Talk about active surveillance, biopsies, consequences, and side effects. So understanding my diagnosis, some statistics, risk factors, prevention. It's the most common cancer in Quebec in men. 4,600 men in Quebec are diagnosed each year with prostate cancer. But there are very few who die from prostate cancer. I think that's one of the very important messages. If you have prostate cancer, the risk that you die of prostate cancer is very small. So it's 1 out of 7 or 8 men who have prostate cancer, but only 1 out of 28 will die from it. You see, the 5-year relative survival is 96 to 100%. So where's the prostate? You don't feel it. It is below the bladder. Here's the prostate. It's below the bladder and very close to the rectum. So when the doctor goes in with his finger to feel the prostate, it's about 2 to 3 centimeters, maybe 2 inches after the entrance to the rectum. You can feel the prostate here. But very few of us really feel it. Only if it's very big, we could maybe feel it. And the urethra goes through the bladder, through the prostate here, through the penis, outside with the urine. So, am I at risk of developing prostate cancer? So it's all a question of age. The older you are, the higher is the risk to develop prostate cancer. Racial origin, people of African origin have a higher rate of prostate cancer. We don't know why. Family history, a very important factor. If you have a father or a brother with prostate cancer, so you also have a higher risk. We talk about that later. Some genes, diet, inactivity. Vasectomy seems to have no impact, is not a risk factor for prostate cancer. In the ejaculation, in fact, some patients ask me, did I have too much sex? No, that's not a risk factor. So very important, as we said, if you have a father who had prostate cancer, so now it's very important, did he have it at age 70, did he have it at age 53? At age 70, maybe the genetic factor wasn't that strong because he had it at a later age. But if he had it at 53, so that's very early, so there's a stronger genetic factor in it, so you are at a higher risk. If you have a father and a brother, 2 brothers, then your risk increases. So it's sometimes important, and I know many brothers don't talk to each other about their health problems. Sometimes it would be good to tell your brothers, I had prostate cancer, maybe you should get tested. Maybe your sons should get tested also. So Angelina Jolie, she has a BRCA1 mutation that puts her at a high risk of breast cancer and ovarian cancer, but it's not that often associated with prostate cancer. It's more the BRC2, not the BRC1. So if there are a lot of breast cancers in your family, or ovarian cancers, or women at young age, maybe you're also at a higher risk of prostate lifestyle, diet, inactivities is a very important factor. So we know that especially Asians have a low rate of prostate cancer in Asia. Once the Asians come to North America, they have a rate of prostate cancer as high as the other people in North America. So we believe there must be some lifestyle factor involved that causes cancer. What is it? We don't really know. But it's for sure that all these good things here are not forbidden. Patients, they get very religious about that. They say no barbecue anymore. I can't eat red meat anymore. Some of the wives go also a bit overboard, but that's not mean. I have to tell you, if your wife wants you to put you on a healthy diet, it's to show you love. She wants to keep you, and it's not to terrorize you. Soy, some patients eat a lot of soy because there are some studies that show that because of the Asian men's and also in animals, if animals who eat soy seem to have less prostate cancer. But you should also be careful. There were several studies with soy, vitamin E, selenium that didn't show any advantage to prevent prostate cancer. So you can't do too much to avoid prostate cancer with your diet. Coffee, that was, I think, published last year. If you drink 6 coffees per day, it seems to be a preventive factor for prostate cancer. I'm not sure it's so healthy to drink 6 coffees or more, but for prostate cancer, it seems to have an effect. Multivitamins can also have a negative effect, so only take multivitamins in normal doses, not in doses that are too high. Dairy products seem to increase prostate cancer. I love dairy products. I don't decrease my intake in dairy products. So you always have to do everything with moderation if you want to have protection with moderation. So it can't really be prevented. There are certain risk factors. Be aware of that and try to live healthy. Don't smoke. Eat normally, some physical activity, try to maintain a healthy weight. In general, we say what is good for your heart is also good for your prostate. So what's typically the Mediterranean diet with a lot of fish, vegetables, fruit, some physical activity, that is also good for your prostate. Symptoms of prostate cancer. So ProCure helped me with that presentation. That was one of the slides of ProCure. I hesitated a long time to show that because it can give you a wrong impression. I would say 95% of patients that I see in my clinic that have prostate cancer, they don't have any symptoms at all. So if you have these symptoms, they're usually not a symptom of prostate cancer, but of another problem. But if you have these symptoms, you have to get investigated. Maybe it is prostate cancer. But early stage prostate cancers, most patients are diagnosed today at very early stage. They don't have these symptoms. Also a very important point that I realized after several years, when you treat patients with radiation, with brachytherapy, and afterwards you have problems with a weak flow or pain or burning, this is not the cancer, but this is a side effect of the treatment. So patients panic after treatment. They have a weak flow or some burning, some blood in the urine. They thought that the cancer came back. No, it is very possible that it's just a side effect. So understanding my diagnosis, screening guidelines. So how do you make the prostate cancer diagnosis? I would say 99% of patients, they first have a blood test, the PSA. The PSA is the prostate-specific antigen. And it's not prostate cancer-specific antigen, but only prostate-specific. That's a protein that's in your blood. If it is too high, higher than 4, your GP might send you to a urologist for a biopsy. Usually we take that cutoff level. Below 4, we don't do anything. If it's higher than 4, usually you're sent for a biopsy. A rectal exam, if there is a nodule, something that is irregular, then you could also be sent for a biopsy, even though the PSA is below 4. So either PSA above 4 or a rectal exam that seems suspicious sends you for a biopsy. So there's a huge discussion about the PSA screening. Who should have that PSA test? And we could have another evening just talking about the PSA test. Here is the Canadian Urological Association guidelines. Who should have a PSA test? Procure first was a bit hesitant if I should talk about it. I have to tell you there are other organizations who say no PSA screening because it hasn't been shown that it saves life. This is very difficult to understand. That's why we could talk a whole day why PSA shouldn't save lives. If you find the cancer earlier, so why shouldn't you do it? This is a very complicated thing. So the Canadian Association of Urology says men from 50 years on should have a test. Even better is men should have it very early, with about 40. And if they have a low value, about 0.5, they know that they have a very low risk to have prostate cancer later in life. And so they don't need regular tests. And from 75 years on, also the urologist strongly suggests to not do the PSA tests anymore. Because there it's really, and this is not disputed, it's really questionable if you need to find the prostate cancer. So there's a big discussion about that, if you should do PSA tests. What can increase the PSA level? So if you have a PSA above 4, it doesn't mean you have cancer. You don't have to think everything is over. So what can cause a higher PSA level? So as I said, PSA means prostate and not prostate cancer. So it can be BPH, that's a benign prostatic hyperplasia, means a larger prostate. That can also, the normal, if there are more prostate cells, they produce PSA, so the PSA level is high, not through the cancer, but through a big prostate. Age, the older you are, the higher your PSA. Prostatitis means an infection and inflammation of the prostate, can be an infection of the prostate or in the bladder, can give you a high PSA. Ejaculation, that makes very small increases in PSA. I usually don't tell patients I don't tell patients to abstain from sex before they have a PSA test. So again, clearly other factors than prostate cancer can cause a PSA increase. So the diagnosis of prostate cancer is always done with a biopsy, and then it depends on several factors. If you do a CT scan to see if there is cancer in the lymph nodes, or an MRI, a magnetic resonance imaging, to see if the cancer grew out of the prostate, maybe in the seminal vesicles that are just around the prostate, or grow out of the capsule around the prostate. After the diagnosis, I'm always shocked how very few patients know these things that I will explain to you now. And I think it's extremely important to know, if you have prostate cancer, know these facts that will follow. And if you already had the cancer and you don't know it, ask your doctors about these things. One very important thing is the grading of the tumor, the GLEASON score. This is a score invented by Dr. GLEASON. Today it goes from 6 to 10. You find sometimes in books it's from 2 to 10, but there were several modifications. Today it starts at 6. And it shows how aggressive the cancer is in the prostate. What is the image of its aggressiveness? I show you some pictures. So the Gleason score is usually two numbers. If you have a Gleason 6, it's a 3 plus 3. You can have a Gleason 7 score, that's a 3 plus 4 or a 4 plus 3. The first number always says which is the predominant pattern. 3 is a rather benign, a less aggressive pattern. A 4 is a more aggressive pattern. So if I have 4 plus 3, it means 4 is you have more aggressive cells than less aggressive cells. Here are some images of Gleason scores. I know you don't want to study medicine here, but I thought maybe you like these pictures. I'm a very visual person. Here's a Gleason 6. Here is the Gleason 6 cancer. These are normal glands. They're round, and in the middle there is the liquid that the prostate produces. It's a Gleason 6. That still looks like glands, but you see that it's a bit darker than the rest. Here a Gleason 7, a 3 plus 4. You have some normal glands, but also some cells, they lose their gland structure. They're just like a field. Here, a 4 plus 4, an aggressive cancer. You have no structure of a gland anymore. You see these things disappeared in here. Or a 5 plus 4, it's all very mean-looking cells, no organization of the cells anymore. So the extent, the staging of the cancer is very important to know also for choosing the treatment. So you have to know the Gleason score, the PSA level, and on the rectal exam if the doctor can feel the cancer, or on the MRI if the cancer was visible, if the cancer grew out of the prostate. So there are different staging systems. Many patients ask me, do I have stage 1, 2, or 3, or 4? We don't use that so often, the 1 to 4. Just go with you through it very briefly. The stage 1 is a cancer that cannot be felt during the rectal exam. The stage 2 is one that can be felt, but it remains in the prostate, doesn't grow out of the prostate. The stage 3 remains around the prostate, but grows out of the prostate, out of the capsule around it, or in the vesical seminals. And stage 4 is lymph nodes or bone cancer. There's also this, that the 1 to 4 depends a bit on the PSA, the Gleason score, the T stage, but let me go directly to that. We usually use the D'Amico classification. It's a bit complicated, but still you should know if you have a low, an intermediate, or a high-risk cancer. So a T1 or T2 means that their cancer is still in the prostate, doesn't grow out. A T3 grows out. To have a low-risk cancer with an excellent prognosis, you need to fulfill all these criteria. PSA below 10, a Gleason 6, and the cancer shouldn't grow out. Now for the others here, you just need one of the factors, and you always take the worst. So if you have a T1, Gleason 6, and a PSA of 30, just because you have one factor here of high risk, you are a high risk. Or if you have a T1, Gleason 7, PSA 4, you have intermediate risk cancer. So what does that mean, low, intermediate, high risk? Risk for recurrence after treatment. After treatment for low risk cancer, you have a chance of being cured of about 90%. Intermediate is maybe 70 to 80, 90%. High risk is 50 to 70% chance of cure. That's why it's a high risk of recurrence. But that depends, these prognoses, these numbers that I gave you depend on many factors. So what's the prognosis? If you have a local cancer or regional in the lymph nodes, you have still a very high chance to live another 5 years. If you have cancer in the bones or very rarely in the lungs or in the liver. Even then, you have several years to live with the treatments that we have today. So I'm talking now about treatment options. Many patients feel a bit like this man here at this game show. There's door 1, 2, 3. First door is a new car, second a Maui vacation, and behind 3 is death. You feel overwhelmed when you have prostate cancer. You don't know what to do. You try to get some information, or you try not to get any information, just to trust in your doctors or trust in your guts. So it's a very difficult situation, and I see that in my practice every day. So what is important to decide for a treatment or not? Age and your expected lifespan. So we said if you are 85 and you have prostate cancer, you might not need treatment because the cancer might grow very slowly and you might die from other things. If you have other serious health conditions, like very grave heart disease, you might not need treatment for your prostate cancer because your heart might kill you and not the prostate cancer. Important stage and grade, your feelings and your doctor's opinion. You have to discuss it with your doctors, maybe with people who had prostate cancer. Procure can help you. And you have to know what are the chances of cure for each treatment. What are the side effects? Can I live with these possible side effects? So what are the treatment options? Depending on the situation, active surveillance, I will explain to you what that is. Also about active surveillance, we could talk a whole evening. Surgery, there is radiation therapy, and in radiation therapy there's external beam radiotherapy, there's brachytherapy, there's hormonal therapy, there's a combination of several therapies. Chemotherapy and vaccine treatment are more for very advanced cancers, and I won't talk today about that. So what are the options for low and intermediate risk cancers? Active surveillance is less popular for intermediate risk cancer, more for low risk cancer. So if you have low risk cancer and your doctor doesn't talk to you about active surveillance, it's not a good sign. Because we know many of these low-risk cancers, they grow very slowly, and you might never need treatment. If you don't have too many positive biopsies, usually we say not more than 2 biopsies, and none of the biopsies should have more than 50% of cancer in it. These are usually our criteria that we use to not do anything. We have active surveillance. And that's the only slide I want to show about active surveillance. Active surveillance means you don't do a treatment immediately. You do repeat biopsies, the first after a year, and then either each year or each second year, repeat PSAs, usually every 4 to 6 months, and repeat rectal exams. So that's usually something patients don't like. That's why often patients opt for a treatment. You hear that joke. Honestly, if there was a virtual prostate exam, don't you think I want to be the first to know? You don't like the rectal exams, we don't like it either. So the Toronto study was just published some month ago. It's the largest study about active surveillance. Patients that weren't treated were just followed. After 5 years, still 76% of patients were untreated. After 10 years, 2/3 were still untreated. Very few patients died from prostate cancer after follow-up of an average of about 6 years, 6.5 years, and very few patients had metastatic disease, cancer in the bones, but were still alive. So this is a possibility if you have very few biopsies, usually not more than 2 biopsies with cancer. It's a question if you can feel the cancer, if you have rectal exam that is positive, should you be on active surveillance? That can be discussed, is also an option. But the risk of progression is higher. Radical prostatectomy, it's also an option for low and intermediate risk cancers. It's the surgical removal of the prostate. The prostate is taken out with a scar here, or laparoscopy, or with a robot, or with a Da Vinci robot. I will explain to you what the Da Vinci robot is. It's an excellent option to remove the gland. You have to discuss that with a surgeon if you're a good candidate or not. And I would strongly suggest that if you have prostate cancer and you're looking at surgery, go to a center where they do a lot of surgeries. It has been shown that if with the experience of your surgeon, the complication rate decreases dramatically, and also the result, the cancer result. So it takes out the prostate. Radiotherapy can be used after surgery. It removes the entire gland. So my friend Kevin Zorn at Saint-Luc Hospital gave me these slides about the surgery, about the robotic surgery. It's really an amazing robot. The surgeon has his fingers here in this, here, and he is looking in here and sees the operating field and operating with these machines here. It's like a laparoscopy. You have several tubes in your belly that helps him remove the cancer. And what is really amazing, you see here the surgeon with his assistant. Where is the patient? The patient is in the other room. So here the patient is in this room with anesthesia, and here he is operating. I think they're not in the same room because these machines are too big for the operating rooms. So he does really an amazing job with very good results. My friend Dr. Zorn, operating time 2.5 to 3 hours, blood loss very little, very few transfusions. But you can also have open surgery. Also, open surgery can be very good, can cure you. If the surgeon is good, he can cure you with an open surgery. He can cure you with a robot. It depends on the skills of the surgeon, not only on the machines. Radiotherapy for low and intermediate risk cancers. Radiotherapy kills the cancer cells by exposing them to controlled doses of radioactivity. It's an alternative to surgery, or it can be used in combination with surgery, but if in combination, then it's first surgery and then radiotherapy. It is very difficult to operate a patient who had radiotherapy and had a recurrence to then take the prostate out. It's very difficult. There are more complications after that. We had a lot of progress. I started 10 years ago, and we had a lot of progress in radiotherapy. So here, external beam radiotherapy. Here's a patient, but don't let this picture fool you. You have to undress here, and you are naked in this region here. Brachytherapy is radiation coming from the inside. I will talk about that later. We put these seeds into the prostate. So external beam radiotherapy for whom? It's for low, intermediate, and high-risk cancers. So you can treat every patient with external beam radiotherapy. It's usually a very long treatment, at least 8 weeks. It's an everyday treatment, at least about a half an hour that you need to calculate in your day. So it's not very good if you're still very active. If you're working, it might be a certain problem. So external beam radiotherapy are photon beams. It's like an X-ray, but a much higher energy aimed at your prostate. And here the X-rays go through this beam, and we have these leaves here. These leaves can be formed according to the treatment plan that you want. That's called, if you look that up in the books, a 3D conformal radiotherapy with the beam formed around your prostate. But there's also something, and when I started, we all treated every patient with 3D conformal radiotherapy, and now we treat all the patients with intensity modulated radiotherapy, IMRT. And I would say most centers in Quebec treat patients with prostate cancer with IMRT. These leaves can move during the time the beam is on, during the time that the X-rays are aimed at your prostate. These leaves can go up and down, and modulate the beam even further than this. And so you can spare healthy tissue much better than before. And we could dramatically reduce the dose around to the rectum and the bladder. That's an image that shows you about what we do. This is the prostate. Red means high dose. Yellow-green means lower dose. Blue is called less dose. So we aim from different angles at the prostate to get the high dose in the middle and try to spare the rectum, that would be here, or the bladder, that would be here. You can see we are not perfect. The bladder receives a certain dose, and the rectum receives also a certain dose. So side effects are rectum, that you could have some, not diarrhea, but that you have to defecate more often, some small portions, maybe even some bleeding. Usually the bleeding comes only 2 to 3 years or later after the treatment. Some bleedings we have to stop with a laser treatment. I have to send you to a specialist for that. About 10% of patients have rectal bleeding. Less than these 10% need actually a treatment like laser treatment to stop the bleeding. The bladder, maybe some urinary burning. 2 or 3 years after the treatment, you might have some bleeding. That's less than 10%, less often than the rectal bleeding, the bleeding in the bladder, caused by the radiation. The radiation makes the normal tissue more vulnerable, and it bleeds more often. That's the reason why you have this bleeding. Also, erections can decrease. If you had problems before radiotherapy with erections, the radiotherapy won't help the erections, can go down further. Maybe you can even lose your erections after treatment. So that's the external beam radiotherapy. Who is not a patient for external beam radiotherapy? Patients with inflammatory bowel disease, that's Crohn's disease, that is ulcerative colitis, they are not candidates for radiotherapy, or if you had a previous radiation to the pelvis for another disease. What to expect? We also do image-guided radiotherapy. We made a lot of progress in that. I'm very proud. I introduced that in Quebec, that we put gold markers into the prostate. These gold markers are not radioactive. We put them in the prostate through the rectum, like at a biopsy, and then every day we see where the gold markers are, and we can aim our beams at the gold markers, because we know there the prostate is where the gold markers are. And we can do that with an X-ray before the treatment, before each treatment, just a minute before we localize the gold seeds in all three dimensions, and then we shoot at them. It's called image-guided radiotherapy, because now you know where the prostate was. Before, you just had an idea where the prostate should be, and this also helps us to decrease the safety margins around the prostate. Because we know where the prostate is, we can treat a much smaller field. A little joke, your appointment with the doctor is at 11:15, but his appointment with you is at 12:15. So brachytherapy, that's my passion. I learned brachytherapy in Toronto, and I came then afterwards here. I see Dr. Valiket is here from urology. The urologist helped me very much. They were very friendly. They sent me very good patients to start my practice before we could really start with our program. So who is a candidate for brachytherapy? It's low-risk cancers and some intermediate-risk cancers. Not all intermediate cancers. Some, we usually don't treat patients with a PSA above 13 and GLEASON 3+4, rarely 4+3, and not too many GLEASON 3+4. We don't treat high-risk cancers. I have just to mention that there is also a high-dose radiotherapy. This is a high-dose brachytherapy. This is low-dose brachytherapy. High-dose is a bit different. It's for more advanced cancers. You put catheters into the prostate. You send a radioactive material through these catheters. You take them out. That's a different treatment. So the brachytherapy, these are these pellets that we put into the prostate. They have a very small radiation radius, so we treat just several millimeters. The advantage is, compared to external beam radiotherapy, is that the tissue around gets very little dose because I go directly into the prostate with the radioactivity. These seeds, they are in the prostate forever. They are not removed. It's usually a titanium shell, and within that shell is the radioactive powder. Usually we use the iodine powder. If you're allergic to iodine, you can still have brachytherapy because the iodine stays in this seed. Usually we put around 60 seeds in the prostate. Again, all over the prostate, in the whole prostate. Not only where the cancer is, because you never know when you have the biopsy, maybe, and this is the cancer, or maybe there's a second cancer, and you just miss the cancer, then you're not cured if you only treat where we know that the cancer could be. So we treat the whole prostate. It has a half-life of 60 days. That means after 60 days, you lost already 50% of your radioactivity. You can sleep in the same bed like somebody. You can be close to children, to pregnant women. You should just not put a small child for too long on your lap on the prostate. That could be too close. You should be careful for about 3 to 4 months, but only for children, because children are more radiosensitive than adults. Also for the airport, we give you a passport because at the border they might ask you why you're radioactive and suspect you of. So brachytherapy, the history, it was in fact invented already in the 20s and 30s, but then abandoned because one couldn't really see the prostate, but one had to feel the prostate through the rectum and through here and say, oh, let's put it through the skin into the prostate. It didn't really work out. But since the 80s and 90s, since the transrectal ultrasound, or if you have a biopsy, you go with the ultrasound probe into the rectum to see the prostate. That's what we do. So that helped us now to see the prostate, and that helped to redevelop prostate brachytherapy the way we do it today. So what are the advantages of prostate brachytherapy? It's a simple outpatient procedure. You're coming for 1 day, morning to evening. You don't even have to sleep in the hospital. Rapid return to normal activity. Patients, the day afterwards, they go shopping, go for a walk. And the results are also excellent. They're very comparable to surgery. So the advantage is that there's a rapid dose fall-off in the surrounding tissue. The surrounding tissue receives little dose. But still, the urethra goes through the middle of the prostate, so the urethra receives also a certain dose. So the side effects are maybe urinary burning, weak urinary flow because of the prostate swelling. You have to urinate more often. There are very rarely rectal problems. We can spare the rectum very well with brachytherapy. Rectal problems like rectal bleeding. So what do you expect when you have prostate brachytherapy? That's our team. We have always a physicist. Dr. DeLuia is also radiation oncologist with me, our therapist to help us in the operating room. It's a preoperative consult, health tests, blood tests, ECG for your heart to see if everything is okay. You have to do a small bowel cleansing. That's nothing to drink. It's not like for a colonoscopy. You put it's a fleet enema. You put a liquid in the rectum the evening before. The day of the surgery, you didn't eat since midnight. And it's about an hour and a half in the operating room, quick recovery. You walk out of the hospital the same day. We have some photos of our unit. So you're at the one-day surgery unit. So how is it done technically? So we put the ultrasound into rectum to see the prostate, and then we go with the needles through the perineum. The perineum is the skin under your testicles. So we tape the testicles up, and we go with our needles through the skin directly into the prostate. The prostate is just very few inches under your skin, and we put our seeds in, take the needles out, and that's it. We don't even cut the skin. We just go with these needles that are very firm into the prostate, and the hole that we made is usually closing by itself. These are the seeds. You can compare it to a nail, a fingernail, and we put around 60 seeds into the prostate. Most patients have spinal anesthesia. It seems to not hurt, be a bit uncomfortable, but maybe 90-95% have spinal anesthesia. If you're very nervous or if there's another concern by the anesthesiologist, you can also have a general anesthesia. We contour the prostate in the operating room to see what we want to treat. This is the prostate here. Here's the urethra that we contour also to spare it best possible way. And here's the rectum that we try to spare. Here are the needles that we put all over the prostate to put the seeds in. Usually we put in 22 needles in the prostate. Here is a needle. It's guided by a template that helps us to be 1 millimeter. We want to be as exact as possible, 1 millimeter correct. This is the famous position of giving birth. We see where we are with our needles with the ultrasound in the rectum. Under here is this ultrasound that goes into your rectum, and we see if we are at the correct position on this screen. It's about an hour and a half in the operating room. So now treatment comparison, low, intermediate prostate cancers. I will compare mostly brachytherapy to surgery because these are the most alike. And also I see most patients choose either. External beam radiotherapy has become less popular with brachytherapy. So this is a very busy slide, and I want to lead you through it. I decided still to show it to you because I think there's a lot of important information on it, and you need to be able to compare it. So I want this. These are our data here from brachytherapy. Here are the data from my friend Kevin Zorn about surgery. Let me start with this table here. Here's the follow-up, 1 month after surgery, 6 months, 12 months, 2 years, 3 years. How many patients were free of any pad? And here are how many patients had maybe 1 security pad, 0 to 1 security pad. You can see after 1 month, 56% were okay with none or just a security pad. After a year, 93% had maybe a security pad, 90% didn't even need a security pad. So in best surgical hands, 10% of patients have some incontinence and need to wear a pad. So 90% means that 90% don't need anything, means that 10% need some protection. Here's erectile functioning. This are patients who had okay erections before surgery. So how many were still able to penetrate 1 month after, 6, 12 months after? So 12 months after, around half were able, but this increased 30 months after to 54%. Of patients who had okay erections, patients who have very good erections, this here, they also had 30 months after, 80% had erections that were good enough for penetration. I want to compare that now to our results. We call them the quadrella. People who go to horse races know what the quadrella is. That's the ability to predict in 4 consecutive races which horse wins. So it means quadrella that you're cured, that you still can have a good sexual functioning, you have no urinary problems at all, and you have no rectum problems at all. The quadrella means you have no problem at all and are cured. So about, if you look at 6 years, 40%, 50%, after 5 years, have everything. The cure rate is very high. It's about 95%. Sexual functioning, these are patients that are comparable to this here, patients who had erections that were good enough for penetrations with or without medications. And you see about 75, 80% after 6 years were still able. Urinary problems, it means they didn't need any medication. Urine was flowing perfectly, 80 to 70% after 5 to 6 years. Very rare that patients have rectal problems like rectal bleeding. So the numbers are very comparable, are definitely not worse for sexual functioning after brachytherapy compared to surgery. Incontinence is rarely a problem after brachytherapy, maybe a certain urgency that you have to go quickly to the bathroom, but incontinence is rarely a problem. That's more a problem of surgery. On the other hand, after surgery, you very, very rarely have rectal bleeding. So, some pros and cons, but this is also, I put it only on one slide. It's also very busy. Let's go maybe through it one point after the other. Radical prostatectomy, the pros is, it can tell you how advanced the cancer was. Before the operation, you don't always know if the cancer is advanced or not. There's 30% of cancers are, after you take them out, you see that they were more aggressive than you thought. And this, you know, after surgery, after radiotherapy, you don't have this information. If you have urinary problems before with your diagnosis, they might be resolved by surgery. Radiotherapy can make these symptoms worse. So if you already have a lot of urinary problems, weak flow, you get up 10 times a night, you're not a good candidate for me. I send you to surgery. Also, the PSA level after surgery is often 0 or should be 0. After radiotherapy, brachytherapy, the PSA goes down slowly, sometimes may even go up a little bit, do what we call a bounce, go up, down, go down again. So this is much less complicated PSA level after surgery. That also makes it, the monitoring after reappearance, very easy. And radiotherapy can be given after surgery if the cancer is more advanced or the surgeon couldn't take everything out. But still, the cons, it's a major surgery. There's some risk of bleeding, of incontinence, and other side effects. The pros of radiotherapy, and I still think it's a very good treatment, although it has a bad reputation. It is a very easy treatment. If you're like me, you're afraid of doctors, of hospitals, of needles, go for radiotherapy. You have a very good chance of cure. It's not an intervention, no operation. You don't need catheterization that you might need after surgery and sometimes also after brachytherapy. It's a very short thing. You come, you leave, but it can be long radiotherapy. external beam radiotherapy. And the PSA afterwards is less straightforward than after surgery. And surgery after radiotherapy is very difficult to do. The tissue is very fragile, bleeds more complications like infections, incontinence, if you first have radiotherapy and then surgery. But first surgery and then radiotherapy, then that's very easy to do with very little risk. So we talked about, let's summarize the side effects. For all the treatments, erectile dysfunction can be one, but it depends a lot on your function before the treatment. If it's good before, you have less risk to lose it afterwards. Urinary incontinence, a higher risk with surgery, rarely with radiotherapy or brachytherapy. Bladder rectal inflammation with bleeding or some burning, more common with radiotherapy and brachytherapy, rare with prostatectomy, surgical complications after surgery. So to conclude my talk, there are several risk factors: age, ask around, diet, don't become too religious about your diet, enjoy life, the barbecue is okay. Overall survival is excellent, many, many years, even if you have a high-risk cancer, as long as it's in the prostate and hasn't spread to the bones yet. Early detection can find localized cancer, but it's debated if it really prolongs survival. The treatment depends on great extent, location of the disease, and your general health and age. Surgery, radiation, brachytherapy are usually equivalent therapeutic tools, but depend on many factors. Brachytherapy offers an alternative to surgery or radiotherapy. So thank you very much for your attention, and I'm taking questions afterwards.
Thank you, Dr. Taussky. Nice presentation. Really, it explains all the different treatments that is available out there. I imagine also with one of your points saying that 6 coffees or more, a lot of coffee shops will be happy tomorrow to hear that news that having more coffee helps you prevent prostate cancer. Okay, our next speaker will be Mr. Victor Glazer. We are pleased to introduce you to a prostate cancer survivor who has gone through brachytherapy in the summer of 2014 following a prostate cancer diagnosis. Please welcome Victor Glazer.
The problem with my prostate started 2.5 years ago. Up till then, I had regular examinations with my family physician, Dr. David Shaheen. My PSA number was always pretty good. But in roughly November 2012, after blood tests, he told me that the PSA number was higher than it should be, and he referred me to Dr. Simon Tanguay at the Montreal General Hospital, a urologist. I went to see Dr. Tanguay, and he adopted the active surveillance method. He said that we'll watch it and see how it goes. But a couple of months later, he suggested that I have a biopsy done, which I had in February 2013. And after the biopsy, I went to see Dr. Tanguay, and he said that they detected prostate cancer in part of the prostate. But the good news was that it was the early stage or lowest category, is the term he used. And for the first time, I heard the term GLEASON number, which Dr. Taussky just referred to. And my number was 6, which he said was the lowest. So I felt pretty comfortable with that. We continued with the active surveillance. I saw Dr. Tanguay several times. And then he suggested another biopsy of the prostate about a year later, so that was March 2014. After he got the results, he said, it's time to do something. I was hoping to continue the surveillance and wait, but he decided I should have something done, and he referred me to Dr. Taussky. I went to see Dr. Taussky in May 2014. We discussed different procedures, including the brachytherapy and the other procedures, and I decided with my wife to go for the brachytherapy because that seemed like the simplest procedure. The other procedure was involved 6 to 8 weeks going to the hospital every day, and that was very disruptive since I'm still working full-time. I went to see, I think we scheduled the procedure, the brachytherapy, July the 8th, and I had to fast the night before. Went to the hospital, got there before 6:30 in the morning, and there was various preparation, quite a few different blood tests, I guess the glucose or different tests. And then we're put into a small cubicle where we have a bed, and then I was taken to the area where the procedure is done. I waited a while there on a gurney, and then I was taken into the operating area. I have to remember this, I don't know if it was the air conditioning or what, but I felt very cold. I don't know if it was nerves or the temperature. And I mentioned this to the nurse, and someone literally pumped in hot air under the sheet or inside, and that warmed me up because I was feeling very cold. I had the local anesthetic. There was just a mild burning sensation, and after that I didn't feel anything. I lied down and put my legs in the stirrups, as Dr. Taussky mentioned, and I don't know the exact time, but I would guess that the procedure took about an hour. I didn't feel anything. I have to say it was done, the procedure, by Dr. DeLuya, because Dr. Taussky was out of town, and she had an assistant. I just learned from Dr. Taussky it was probably the physicist. And one thing I remember clearly, it was kind of almost amusing, even though it's a serious procedure. Every now and then I heard the word from the assistant, bravo, and then bravo, and then I heard a grand bravo, and it reminded me of someone shooting darts, hitting the bullseye. I didn't know what was happening, but I guess it sounded good because she was successful. I learned just today from Dr. Taussky that bravo and grand bravo are areas of the prostate, which I guess she was aiming at. In any event, it went well. I was taken back to the cubicle, and there was a slight downside in that normally most patients don't require a catheter in order to urinate. I did, and I had difficulty urinating, and a catheter was put in. I don't know at what stage. I guess I was still anesthetized, so I didn't feel anything. And the arrangement was that I would have the catheter removed the next day at a CLSC. But I stayed, it was quite a long day. I stayed because of the complication with the catheter. I may have been there till about 8:30 at night, and then my wife drove me home. The next morning, I had the appointment at the CLSC to remove the catheter, and I was told that if I have difficulty urinating, then I have to come back in the afternoon to put another one in. That was the downside. Unfortunately, after it was taken out, I went back home and I had great difficulty urinating. So I went back to the CLSC and to get a catheter put in, and I have to say that that was painful. Just a minute or two, but there was some pain involved there. Went back home and I decided that I didn't want to take a chance, so I would keep the catheter in until the following Monday. It was on a Wednesday that I went to have the catheter put back in. The catheter, in case you're not aware, you have a plastic pouch strapped to your leg, and the urine goes into there, and there's a valve, and every few hours, or when it gets almost filled up, you empty it in the toilet. No real discomfort, it's just a bit of a nuisance. I took it easy for a day, and then I went back to work with the catheter and the pouch. Monday morning, I went to the CLSC. The catheter was removed, and luckily everything was fine after that. The main side effect I had was for a number of months, 4, 5, or 6 months, I would suddenly get the urge to urinate, and it would come quite suddenly, and you had to get to the bathroom. It's much less now, hardly any, and there's virtually no side effects. I'm quite active now. I was asked to say, how do you feel now and how active are you? I'm doing, I'd say, everything I did before. I'm still doing now, activities, working, etc. I was asked to say how I, or what advice I would give to someone who's diagnosed with it, and also what was my reaction at the beginning when I was told of the prostate cancer. I have to say that when I was told that it was the stage 1 or the lowest category, I felt very comfortable. I really didn't worry. I felt, well, there's an excellent chance of full recovery, and apparently there is. And as far as advice to people who are diagnosed, I would say even before you're diagnosed, it's important, it's essential to have a good family physician who's conscientious, and when he sees that a number, whether it's your cholesterol or your PSA or anything else, is very high or higher than it should be, that he sends you to the specialist who can look after it. And that's what happened in my case. As soon as the PSA number was higher than it should be, I immediately was sent to the urologist. And when you're diagnosed, you have to be optimistic and you hope for the best. And one last bit of advice I would give is, when you're going to doctors, if you're married, bring your wife, and if you're not, bring your girlfriend, because they tend to pay more attention to what the doctor says than the man does. And I know that's the case with me, because many times when we'd go to a different doctor, my wife would say, well, he said ABC, and I may remember A and not the BC. So it's always good to have someone with you. That's it. Thank you.
We'll take some questions from the room and also from the web. You can go on the on the web. You can go in the question box and ask your question, or here in the room you can use the microphone and ask a question to Dr. Taussky or Dr. Glazer or any other.
My name is Robert, Dr. Taussky. Shalom. How is the immunotherapy going along with the prostate cancer compared to the brain cancer, for instance?
Immunotherapy is more for very advanced cancers, the vaccine treatment. That I didn't cover that because it's I talked about radiation and surgery.
But they're getting beautiful results lately, and we should be very optimistic with cancer for results.
I'm not aware of the immunotherapy trials now.
Oh, you're not?
No.
There was a 6-hour documentary last week by Ken Burns on PBS, from the birth of cancer, all research for 100 years, and now with the immunotherapy, they're taking your cells from where you have your cancer, they're putting it for culture, and re-putting them back into your cancer place. It's like a Pac-Man. It seems like they're eating all the cancer cells. And after 2, 3, 4 years now, people are out of brain cancer and other cancers. I thought it would be something in the prostate that you could use.
I'm not aware of that.
You're not aware of that?
No.
Shalom. Thank you anyway.
Merci
beaucoup.
Thank you.
Hi. I'm 77 years old. I was diagnosed last fall, and came after a biopsy. The doctor came up with a GLEASON score of 8. However, I was told that it's totally contained and in the prostate and did not spread, nor did I have any other problems. This was decided upon after MRI and a CAT scan. I was on Casodex for 30 days, and afterwards they put me on the Eligard hormone therapy, which is supposed to be a 4-month, each segment would be 4 months, 5 times. Now, as I understand from reading and checking into it, that the hormone therapy or Eligard is not a cure. Could you elaborate on that?
Yeah, for some aggressive cancers, we use hormonal therapy. Sometimes hormonal therapy alone. Sometimes we combine it with external beam radiotherapy, like GLEASON 8. So do you know if the cancer you said was in the prostate only? There was nothing in the lymph nodes? No. So usually we combine that also with radiotherapy together to cure. The hormonal therapy alone is here to control the cancer for several years, but doesn't cure, as you said, yeah. Do you know why you weren't referred for radiotherapy?
I'm supposed to be going for radiotherapy starting next month, but it hasn't been confirmed yet.
Okay.
There was an appointment made and then they canceled it, so I will find out probably by the end of this month.
You don't have to worry because the hormonal therapy takes good care of your cancer, so it can spread. At the moment, your PSA may be very low, and
it went down to 1.5
yeah.
from 8.7 originally.
Yeah.
It's okay.
So there is cure with the radiotherapy for you. Yeah.
We have a question from the web. En français, peut-on avoir une curithérapie avec un PSA de 14, GLEASON 4+3? Et deuxième question, pourquoi un PSA peut augmenter en flèche, cause, exemple de 8 à 12 sur une période de 6 mois?
So should I answer in English or French?
Either. It's your choice.
Okay, it's difficult for me now to change. So usually we don't do brachytherapy. The brachytherapy I showed for that cancer, usually we can do a high-dose rate brachytherapy. It's a bit different. I mentioned that just briefly. This you could do, but not the low dose, the seeds. So the PSA went from 8 to 12, if I understand correctly.
Yeah, 8 to 12. Yeah.
That's not dramatic. It went up, but it could be the cancer that is growing, but it's not very fast.
Another question from the web. Having had my prostate removed last year, 52 years old, with Da Vinci, my PSA levels are still high at 1.76 from 26 before the operation. Why is it still high? Why is it I still have high PSA level at this time?
I assume that there's some cancer still there. And you should discuss with your surgeon if he wants to send you for radiotherapy, maybe.
Any other question from the room? Yes.
I had a radical prostatectomy 9 years ago. I'm 82. And my PSA has risen from 0.0 at the time of the surgery. Now, 9 years later, it's 0.4. Would you suggest radiation at this time?
This is a very low PSA, and it took you very long to get to a still very low level. I don't think that you need radiotherapies. You know, just what you present now to me, I don't know all the details, but I don't think so, that you need radiation.
Is there a chance that the seeds might come out with the urine? That's the first question. And second, if you would like to comment on the reactions that happened to him 5 days after.
Yeah. Okay, yeah, some seeds can go through the urine, come out. Even rarely they go to the lungs with the blood around the prostate. Very rarely can go there. They don't cause any problems, just that could happen, or you urinate them. It's true, I think it's very authentic what Mr. Glazer said, and I'm happy that he's not the ideal patient who never had any side effects. So a third of patients leave our unit with a catheter in place that we usually take out, that they go afterwards to the CLSC, we take the appointment, take it out, and usually it works. So very rarely it doesn't work immediately, and the catheter has to be put back, and we usually wait for the Monday after to try it again, to take it out.
Would the seeds be a hindrance to an MRI after that because of the metallic nature?
Very good question. No. We even do now MRIs after the brachytherapy to see if we did a good job.
You talked about a biopsy being guided by ultrasound. I understand now sometimes the biopsying is guided by an MRI. Is that true? Do we do that in Montreal? Do you recommend it? What do you have to say about that?
Oh, that's the hottest thing on the market now. You touch now something. Biopsies MRI guided. I don't know if it's done here. You can make, it seems a colleague just shows me, no, you can't do it. But that will come in the future, that you do an MRI and you see suspicious lesions, and then you do with the ultrasound, you can superpose the MRI on the ultrasound and biopsy precisely that lesion that you only see on the MRI. But it seems for the moment not. It costs several $100,000. If you want to make a donation, I would take it.
Dr. Taussky, 2 questions. One is that complicated slide you showed us before, with comparing brachytherapy with Da Vinci scores, I think. Where can we get it?
Where?
Where could I see this slide and have access to it? Because it's kind of complicated just to see it for 2 seconds.
Good, yeah.
Okay, thank you. Second question. Can you say anything about the proton beam therapy? I know it's not available in Canada, but it's a similar kind of stuff.
Yeah, proton beam therapy is even more precise than the photons that we do here for radiotherapy. It's not available in Canada. There are centers, they cost I think 20 million or more in the US that they treat. So we usually, it's not really recommended for prostate cancer because the advantage doesn't seem to be here for prostate cancer. For other cancers, yes, but not really for prostate cancer. There even has been some discussion that protons give higher complication rates. So there was quite some discussions last years. last year. But it's not worth it. With our new technology that we have, I think we can do a very good job. You don't need to pay so much money and go to the US.
Just wanted to say that at one of the hospitals, they're doing a research project where this summer I had 25 high doses of radiation compared to the 33 or 40, and I think it just made life a little bit easier only having to visit the hospital 25 times rather than the 33 to 40 that many of my friends have had.
It's true, I had it in the small print. Yeah, you can give 39 treatments or 20, 25 treatments, that's true, to make it much shorter.
Any other questions?
Actually, two questions. How long is hormone treatment good for?
Can you be a bit more specific?
Well, I started in September. I'm 80 years old, and my GLEASON is 8 to 10, and I'm doing fine. I go skiing with it and everything else. But
so that's your sole treatment, hormonal therapy?
At the moment, yes.
Do you have it for a recurrence? Or?
No, I never had it before.
Okay, so for many, many years. Hormonal therapy, 5-7 years often, that it's effective. Yeah.
Second question, how definitive is the PSA test?
How?
Definitive. How exact is it in the sense, does it cover it all or just a little bit?
Oh, it's not at all. That's why there's such so many discussions about it, how important it is. So there are two things. One is to detect cancer. For this, PSA is not very good. You can have a PSA of 2 and still have prostate cancer. You can have a PSA of 6 and not have cancer. But to measure the treatment response, PSA is very good and very reliable. If you had surgery, the PSA is 0, you can rely on it. If you have hormonal therapy and the PSA goes down to 0.5 to 1, a good sign. You can really rely on that.
Thank you, Dr. Taussky, for everything you're informing us about tonight. A question, you said on a couple of times, just in passing, that radiotherapy kind of has a bad name or not as good a name as some of the other treatments. Why do you say that?
It's because of the complications that it gave, like rectal bleeding, urinary bleeding, some other rectal complications with the techniques that we used before.
Again, Dr. Taussky, can you say anything about the PCA3 test? Because I'm going to get the results next week, so I'm wondering whether or not I made the right investment in getting that test.
The PS3 test, you say? The PCA3 test? Yeah. The PCA3 test. Yeah, so that's a test in the urine that can help decide if you should have a biopsy. If you have a higher PSA, it can indicate if it might be prostate cancer, the reason for your higher PSA. It's a big discussion here in Montreal. People are not so sure, we say in French, for it, but in Quebec, they're doing that much more often. So I'm really neutral about that test.
My question, continuing on what I asked before, after radiotherapy, is there a reason for continuing the hormone therapy for another 2.5 years? Will that, what will it do?
It's in fact a big discussion. How long should you do the hormonal therapy with radiotherapy? Should you do it just for 6 months? Should you do it 2.5 years, 3 years? It depends on many factors. It depends on how, if you have other problems like diabetes, heart problems, then you would maybe do it shorter. If you have many high aggressivity factors like a high PSA plus, a high GLEASON score, plus on the rectal exam a big prostate that grows out of the prostate, then you would maybe do it longer more than shorter.
I do not have any other health issues whatsoever. And as far as I'm concerned, the side effects of the hormone therapy, I don't know if it outweighs the benefits or not.
It's very difficult for me to say that now here with what I have.
You have a question from the web. There's always a risk of prostate cancer returning after radiation therapy, more so than with surgery. What percentage of risk is there with brachy versus radiation? I'm 58, on active surveillance since 2009, and wonder.
I believe that after brachytherapy and surgery, the results are at least the same concerning cure. 95% cure that has been shown elsewhere, and our data show the same. So I think it's very, very comparable at the two treatments.
Any other questions? Thank you very much.
Thank you.
This concludes the evening. Extend warmth and thanks to our speakers, participants in room or on the web, and to all of you in Brome-Missisquoi. Before you leave, please fill out the survey, paper or online, bottom right corner of your screen before signing off. This allows Procure to develop educational activities and content that meets their needs. Finally, we would like to remind you that to register to our Walk of Courage on June 21st on Father's Day in Parc Jean Drapeau. Our next conference will be this October in Quebec City on Incontinence. Call, write us, and visit us on our website. Procure is there for you. Thank you very much. Good evening.